Hello, I'm Dr. Bill White. I'm a general dentist who has spent the last about 45 years doing nothing but orthodontics and some TMJ work that's mixed in with orthodontics. And I'm a member of the American Orthodontic Society, and this is an organization of general and pediatric dentists that its sole purpose is to teach orthodontics to other general and pediatric dentists and any other dentists that are interested in studying orthodontics or having it as part of their practice. This is the second phase now of a Class 2 Division 1 series here that I'm showing 4 cases. I have 2 more to show in this second phase of it. The first case is an adult, Class 2 Division 1, and we did extractions of all 4 first bicuspids on this particular lady. And the last case is a non-extraction case. So anyway, we'll head off into this and try to show you the ways that we do things with it that may interest you. Now this adult has a little excess vertical height of the face. You see this distance here down to here is too much. You'd really like to stop it about on you, like for her chin to be down about here, you know, a bit more normal. But as the bite opened from probably mouth breathing and function like that, and these posterior teeth erupted toward one another, and then the chin moved down and it swings from over here, and as it swings back it kind of does like a hinge or a gate or something. It drops back. So if you could bring it forward, she looked like she has more of a chin than she does here. And so we're going to try to bring a little bit of the profile in here and bring a little bit out here in the front as we go through this part of the treatment. And looking from the front, her front teeth are kind of protruding and you see them, but she doesn't look all that bad, and this is not too great of an open bite skeletal situation. Now when we look at her models, this was back in 1982, so just because it's from 82, the same thing is true today as it was then, the way people grow. But she had apparently I don't know whether you call it a tongue thrust, or she had sucked on something, or she was breathing through her mouth. She had some functional problem. I'm sure that we try to find out and try to address the problem if we possibly can. From the side, she's got a tremendous overjet, overbite, and then a close bite too. Her lower teeth are up in here somewhere. So if we reduce the number of teeth in here, you put the same force on fewer teeth, you can get the vertical part of the face to close down to some extent over a period of time. If you find out the person is swallowing improperly, and you teach them how to swallow and get them airway opened up where they can breathe and they swallow, then this continuous pressure of swallowing tends to reduce this vertical height of the teeth, and they'll tend to be forced down over a period of time. So I've had adults that the vertical height lowered over a long period of time. Now you could treat the case without extraction if you wanted to, but she'd probably be too full, and that would make it more difficult to close it down. So anyway, on this particular person, we're going to come in here and take out these 4 first bicuspids, and you can kind of see what happens in the case. Now, right all over these as we go to kind of show you what we're trying to do. We're going to try to bring this cuspid back into here. Now you'll need to bring the roots and everything back, as you do this, and we'll bring these teeth back also, and we'll change the torque course of the upper anterior teeth. The other side, same thing, maybe not having to go back quite as far with this, but we're going to extract those bicuspids, both upper and lower. Now she's got all this spacing in here, which kind of indicates she's got a lot of tongue pressure is far greater than her lip pressure, and so these teeth are being forced out here, and the lips, the seal and everything is not good enough to pull this back in, so she's almost certain to be breathing through the mouth. So if we can get people into ENT people, or if we can get somebody to work on the allergies there, and get rid of the allergies where they can airway opens up and they can breathe through their nose and not their mouth, it makes a tremendous difference in the way the teeth do, and it just makes a difference in the general health of that particular person. Okay, the bottom teeth now, it looks like she kind of sucks the bottom lip in like a tongue thruster, and you see these teeth have been pushed back here. Let me go back and show you these teeth have been pushed out. So if you take a person swallowing like an infant or an infantile swallow pattern, they'll suck the bottom lip in and they'll push their tongue up in here. So it's almost certain that that's one of the reasons for this being there. Now if you can get at the reason of these things, then you can do the correction much easier, and the retention is far, far better if you don't get at the reason. And if you turn loose the case, don't keep all kind of retention on it all the time, it will relapse, that's for dead sure. So we're interested in finding why they went that way. Okay, so here we extracted the teeth. Now we're way on into the case. I took the teeth out. Now you've got to open the bite, and so here we've got these intruding arches, something I came up with quite a long time ago, back in the early 70s. Now this arch, this wire here, auxiliary wire, comes out and drops down, and you'll have a kind of a deal like this coming off, and it'll come all the way around, come back on the other side, and have a similar deal and be activated, something like that. And you bring it, excuse me, these things keep coming up here. You bring this wire up and hook it to the highest part of the teeth. Well, it pushes these teeth down. It tends to push this up, but it forces these teeth in contact back here. Now if it's a real high angle, we like to come in and put a blocks over these teeth, and so the person's chewing keeps these teeth from erupting toward one another. Now this one went up like this, and we bring it down, and it's tended to pick these upper teeth up, and we've got another, your conventional arch wire in there is pulling this back and also correcting the torque. You see this is a rectangular wire in there. The mechanics looks pretty complicated, but if you stay in there and watch what happens, this is the best way in the world that I know of to level a bite. and you can actually put this stuff on. Now here we put it on later, but we normally now put a little flexible wire in here and put this on day one, to open the bite like that. So anyway, we get it open that way. Now the rectangular wire is on the teeth, and we used a round intruding wire. Normally we have a round wire or something in the brackets, and we bring our intruding wire down and hook it. So we brought it down, kind of dropped it under these teeth. It's picking them up, but we've got the rectangular wire in the bracket slots to control the torque as we bring them back in. And we'll show you, well, I'll talk about it a little bit while we're here. These brackets, I think, are one of the best brackets. You have these little wings on them, and you can bend the wings, real soft material. You can bend the wings up without popping the brackets loose. If you bend this labially, then you put it in, then it makes the tooth go this direction. It rotates it, or however you can control rotation real good with these little winged single brackets. It also gives you a great big inner bracket space in here, which allows you to bend or flex the wire more if you go back in. It's an excellent idea. They're Lang or Lewis brackets have these wings, and they've been popular for years, and they're still good. And I used them for a long time. Back before we had good sealants, I tended to get food underneath here, and you couldn't get, or the people didn't get a lot of it out, so we got some decalcification that I didn't like, so I just went to single brackets. We learned how to rotate with them. But these are excellent brackets to use now. Your twin brackets are okay, but your inner bracket space in here is certainly limited, where if you just had a single bracket in here and a single bracket over here, your inner bracket space is much greater, so you can bend the wire more efficiently and engage it in the place, and you can put more torque and stuff like that where you've got a greater inner bracket space. Well, so much for that part. Now we've already closed the extraction sites, which are easy to close, but if you're not used to taking out teeth or having people come in with missing and bombed out teeth and closing space, sometimes some of the people in our organization in their studies in orthodontics didn't get enough information on closing space, so it's not a difficult thing to do. We'll try to cover that in all these different videos that I'm going to talk about. Okay, so we got the brackets, we're back, the space is closed, and we've got the teeth in a pretty much class 1 relation right now, and the bite is open. The lower teeth that used to be in the roof of the mouth are open and down, and these are down, and these are up, and this is back, and even the molars are back. We move them back. We can cut them with class 2 elastics, or we use headgear. Now we use the headgear on this case in a very different way, which I'm going to try to show here. I think we've got plenty of pictures of it, and I'll try to show you exactly how we use this headgear. Okay, so we've finished the upper, got it back, so we're going to come out of it early. We still got the braces on the lower teeth, and we'll put a retainer up there. It has a bite plate and all. We don't cross the occlusion now with anything, so this will just have a labial wire come around, maybe a expansion loop somewhere in here, and we solder it around over the molar area. And So we still have the molar bands on. On this particular case, we kept them because I was concerned it's an older patient. Back then, I don't worry too much about that now, but back in the 80s, first doing these, I wanted to make darn sure they stayed. Now the lower is still got some spaces in here, and we'll go ahead and close that and probably put some kind of fixed. Now we'll put a fixed retainer on for certain. So here is the lady. I think this is after we finish, but the vertical height isn't great change, but it's better than it was. And we'll look at the smile line. When she smiles, the lips come up above the teeth, but don't show a great deal of gum tissue in here. And that looks quite good. Let's look now at this is the retainer that we put in, and we put the retainer, we built it with the 6-year molar bands on. Now I'm going to show you, we thought we might lose some of this correction on this lady, so I came in and put little composite amounts right above these central teeth. If you look close, you'll see slight composite wedges above that. So she puts a retainer in, but this wire comes up there and it stops in this area. And we have it over here, but we have a inner bow of the retainer, the headgear will have a spur that goes back and hooks in here. And we put force on that. And actually you can correct one of these cases with a headgear like that. You know, it'll open the bite, and it may be a little confusing to those of you that never have used them. Now, when at this time, this is 1986 now, we took everything off the posterior molars and bicuspid there, left the brackets on these teeth right here. Now we don't do that at all. We go ahead and bond our 3-to-3 on the back side of these teeth and get it just like we wanted. Then we take everything off the lower like that. Found out that works a little better for us. Okay, now here is a occipital type headgear, and it has this little tongue on it. You see that tongue going back, fitting under that wire. Now this wire will not go up unless the teeth go up, and so we got the teeth controlled here. We're going to elevate them, and so we can run this arm of the deal out, and if you have the arm going across about this portion of the teeth in here, it'll pick the whole maxilla up, and you're pulling from the occipital bone up above, and this will tend to move everything up in that direction. We just did that for some precaution on this. I don't do that now. We just get them corrected like we want them, and make sure the class 2 is completely corrected, and give them a little time to stay there. Don't just correct it and jump out of the case, because it'll bounce back part of it. So here's this little tongue. You see it comes off the headgear. It fits under this retainer wire. Now you can use this same technique when you've got an arch wire in here. See that pick up your anterior teeth. Now if you're using a lot of class 2 elastics to correct the case, they pull down on the teeth, and you can counteract that with a occipital headgear with a little tongue on it like that. And that's still excellent way to do orthodontics, which people are running away from headgears, but they're a very good thing to use in orthodontics. Now this retainer's fitting in there like that, but the headgear went in these tubes right here. Now you can leave that on for and she can wear it if it slips and you're losing a little of your correction. You can wear that at night around the house a little bit, and it'll actually improve the case if it tends to relapse on you some. So we have a bite plate on the retainer and all this, and this is not as necessary now as I thought it was back in the 80s. I didn't want this case to slip any. So now here we've got, you get the teeth interdigitated, but we're having a little trouble now with the lower arch expanding. We've got some spaces in here, and that one's kind of rotated back, so it's not just perfect. But we would hold them in there a lot longer now and keep it. And then we would bond this in there where there would be no separation. It would also tend to prevent this from happening where you got a little rotation of that tooth there. Now, if your interdigitation is real good in here and you've got a tiny space between some of them, it's almost necessary to have the space because the point of the teeth goes down in a groove here, and it's hard to keep that together if it's hitting high on one side and not on the other. So anyway, we had a little bit of space in there. That's 1987. And that space, I think we just left the case with that space in there. Well, I don't know. Let me back up. This is 1987, and we watched this case for a good many years, as long as I can get them in. Now, they've got a tori in here. You see, those things don't seem to bother us at all. It crowds the tongue and maybe makes them use the tongue in a different way. Now, that's 87, and there's 94, so it's 87, that's about 7 years later, with her functioning and eating and having a little bite plate on it. I apparently didn't ever have any retention on this part of the mouth other than this biting into that bite plate up above. And now the space is close together. In other words, the function and the teeth is kind of drifted this way, and maybe they wore down a little bit. But anyway, it closed up. We got a little deep problem with this here, and this tooth right here is still rotated just like it was. Now this may be the way the lower anterior tooth meets the lingual side of the upper anterior. I don't think I've got a picture showing that. Now this, the teeth still look good. The smile line's great. Now this just goes back and shows a few of the mechanics of it while we made it. There's the intruding wire. This is kind of backing up here to show you how we did the intruding wire. Now this wire would go way up like this. As you pull it down, it tightens that spring, you see, and then it wants to pick this up. And this one, the way it's made right here, it would be going way down here, so pull it up. And this is the best way I know of to open deep bites. And it works great on adults or young people or anything. And that's showing that again. Now, this tooth is rotated a little too much that way. I like to bring it around. That'll pull that back in some, and we'll close this gap right up here. Excuse me, I'll have to erase that. Now we're back, and this is before we finish. Now, this is just bring you up to date on some of the extraction. Now we took the lower teeth off first, the upper brackets off first, and we built a retainer, and we'd put the bite plate over this retainer too, right here. So Now there it is. That's 1985, 86, 86, and the picture was taken without the teeth being together good. Now we've got this retainer fitting, it's got a bite plate, and the lower anterior teeth made this little groove here, so every time she bites in here, the teeth go into this area. Then we've got a little marginal ridge here that's higher than the other, and probably the lower tooth, if it hits this on one side, it'll turn that tooth slightly. So a lot of times we go in and smooth, most of them got big marginal ridges, we smooth them out so that the lower anterior teeth hitting those areas, it doesn't make them rotate like that. So again, there's the headgear. It's an occipital type headgear. Picking that up, and we wore that after we've finished the case, just for some time. Now coming across the top is going good. Some of this is repeating for you, but here it was in 82. There it is in 94. So it held up quite well. The midline's not perfect, but the teeth went in. There was the class 2 problem. As the class 2 is corrected and the vertical height is down 82, 94. There's the upper in 82. There it is in 94. That's the upper retainer in place. We took the band off late, so you got a little space in there. We probably brought these teeth together, or they closed together, where we had that band on for a longer period of time. Now the lower teeth that had been pulled back in like this, now they are lined up like that. The space is closed. That's 86 and 94. A little bit of relapse, but not a great deal. Excuse me, there was the smile, and there it is, the profile. That was the profile to start with, and so here's the facial from the front. To start, you see these teeth protruding out here. We brought the profile back. Now you see this is in some. The chin is up a little bit, and the chin seems to be, if you close this up, the chin moves forward, so it's a little bit further forward than it was. If you went back and looked at this profile here, you see the difference there. And that's the facial structure in 94, and that's her smile. That's after started in 82. This is 12 years later, and I'm sure she would look good if you went. That's the profile. Okay, that's case number 3, but we're now up to case number 4, and I'll try to go quicker because we've already been in here 28 minutes. This young lady has done just recently a non-extraction, and she had a functional problem which we hope that we got rid of, and you can see the profile back like that. Took a lot of facial pictures with the front teeth sticking out. She swallowed wrong, I'm sure, and breathed wrong. Now we'll look at the teeth there. The upper anterior is protruding way out the same way that the lower anterior is biting into the roof of the mouth. I mean, she's actually chewing her gum tissue back like that. And we're going to open this bite and bring this back. She was a very good cooperative patient and wore everything we had her wear. Now you've got a kind of a V-shaped arch, kind of like that. We'll bring this back in and have a better curvature to the arch when we finish the case up. Down below the same way. See, she pushed these teeth in. She's swallowing them properly, pulling the lower lip back against the lower teeth and pushing the upper teeth out with it. Here's the models. This was 4/28/11, and you can see now all these model pictures on that same date. She's got a, looks like 12-14 millimeter overjet there with an extreme closed bite. And looking at it from the front, you could see the models, and there's where she was closing in. She would bite too and hit her teeth into that. And when you put the models together, it's actually further back than that. So she brought her jaw forward a little bit to take those pictures. Here's the other side. It's definitely class 2, and of course we're going to try to move everything back like that. You know, and this tooth right here this should end up in this area, something like that. So the mechanics are very similar. We did use some headgear in correcting this, and you can look down and see the models. So here we are, the upper, we got it kind of leveled out quicker. The lower had we've got a intruding arch on here, bringing it down, and it tends to pick that up back to the back. So there it is. We were closing space and or just pulling teeth back. You know, we didn't take any teeth out on this case. Now you can see as these teeth come back, we level the arch out, and these are going back and down. And actually we'll pull the bottom teeth forward. They'll come forward, and we'll use this headgear to kind of make sure the smile line and everything comes out better. And I'll run through this pretty quick because we've been in here about 32 minutes now on this. Alright, here's 8/25/11, and we've got this bite open part of the way, but you might as well not try to back it up when it's still got a real bad closed bite, because you just push these teeth into these teeth back here, and you want to go down with these. So this should go ahead of bringing this back. In other words, you want to get these down so you don't tend to push. If you push these back, you'd be pushing the lower teeth back at the same time. It's not mechanically, that just doesn't make sense, but people try that. Alright, this is the elastics we're pulling back, and we have her using a headgear to hold that up good. So we'll go through this pretty quick. As we were lowering this down, you see it tends to push this tooth back. It cocks it back a little bit, and we bring that, so then we hook onto it. We're pulling it forward too. So as we pull this forward, it's going down, and we open the bite so the upper anterior teeth don't run into this. Now this is, I don't know why she did her eyes like that. I must have been over on one side, or somebody was. Now this is an occipital headgear. It's put here. The arms of this are right across, probably through the first molar of the second bicuspid. It's picking this whole thing up. As you wear a lot of class 2 elastics, it's going to tend to pull this anterior down, but we elevate it and back it up with this headgear. And she wore this thing religiously. Just a good patient. And you can just do a lot of things with it. You get cooperation from the patient. And I don't know why she wanted to look like that. But now the occipital pull, you see this is short in here, and so it tends to pick the front part of the mouth up. If you want to bring this up more in the front, you can make these arms shorter, bring them out like this and pull across this area. If you want to pick the molars up, you make the arms go back in this area, and it'll tend to pick the molars up. But basically, you want to take the whole arch and go up with it, maybe a little more in the front than you would in the back. And I'm drawing all over these, so just get the point across. Alright, so the teeth, they were up in the roof of the mouth, now are leveled out. We still have got to torque this properly and everything and bring these teeth further forward here on the anterior, and we'll continue to do that. Now this is 10 of 11. I think we start out 4 of 11, so we're not in this very far at this time, but you can do these cases in a relatively short time if you get good cooperation out of somebody. By the way, the brackets don't make the case go faster. That is a ridiculous thing. We'll buy these brackets and it treats so much quicker, and that's ridiculous. You can do it with any kind of brackets. I like the narrow brackets that give us more inner bracket space, and that's just little tiny narrow brackets on this case. Now they're getting pretty close. Now here we are, 12-11, and we just about corrected this case. I'm going to go on through pretty fast here, and we put this lacing on here that just, you tie these front teeth together, so if you're pulling back with class 2 elastics, you don't separate these teeth, because if you pull on this, it brings the whole front part back at one time. They're tied together. You leave that inner lacing on. You can change the arch wire, and just leave that little wire. Let me erase that. You see this little wire going across like this, and you tighten that thing up and twist it down. You can close space above really easy with that. So here we are with the class 2. We're almost finished with the case, and we've got her back now almost interdigitated into class 1. It's just like very little. And this is 12-11. So we started 4-11, and we're virtually finished the case. Sorry we didn't get some good facial pictures, but we take this off, and this is 12-11, and I think we started at 4-11, and you've got the case virtually finished. It's all, well, it is finished, except that the final part takes place in the retainer, and the teeth erupt together. We've bonded the lower anteriors together, and here she is later on. She's wearing a retainer, and where she was reversed, she looks like she's got a pretty prominent chin now. Close that down, and she's wearing a retainer, and it worked out quite good, and she was very cooperative. She had no wisdom teeth, and the teeth back here may be in between a wisdom and a 12-year molar. They probably didn't get in the mouth quite as quick, but there aren't any wisdom teeth there. And these are x-rays we just printed out on paper, and I took a picture of them. They're not the best deal in the world, but the teeth are erupting together. Now this was a Panorex taken with a block between the teeth. I don't like that. I like to take the Panorex and show me where the lower molar and the upper molar. So this is class 1, and this is pretty well finished in here. Now that's doesn't show the molar out, and it's good. So as we finished on this Panorex, the molars look like they're edge to edge, but when you look at them to the side, they were more class 2. Well, I take that back. This is when the bite was deep. This was before we started the case. I'm sorry. I don't have the dates on it. Okay, here's the starting x-ray. This was taken in 4/28/11. So really that's almost the 5th month, and we finished this case by the 12th month, you know. And now look at it. This is 4/11 or cephalometrics, and then this is, I don't have the date on that, but it must be around 11 or 12/11, and that's when we finished the case like that. And here's another view of it. She's got a good airway and everything's functioning good, and she's remained that way. So there we are, 4/11, and that's the end of this series. And I'm going to pull over here and close this out. Stop.